A very good day, my dear postgraduate students. The topic of graft versus host disease can be a SNP or a short essay or part of an essay. Let us see what it has got in store for us. Always I used to say, think of the subheadings. And these subheadings you shall deliberate upon before going into the text form. And for the exam going students, it is never too late to start heading in the right direction. Seth Godin. A wonder star, Sunita Williams. We all hope that she returns from space for the benefit of mankind. The graft versus host disease broadly divided into acute and chronic. It has got major morbidity and mortality incidents. And in allogenic hematopoietic stem cell transplants, the morbidity can be as much as 30 to 40%. The diagnosis itself is complicated, not as specific as for the tissues. The staging varies, and the National Institute of Health has given certain guidelines. The mortality is this and morbidity up to 75%. Incidentally, the textbook for nurses gives us a wonderful backup and a very palatable reading. The acute reaction is the reaction of the donor immune cells against the host tissues. It mainly affects the skin, liver, and the GAT. Specifications we shall follow. Chronic, on the contrary, is a syndrome. It resembles other autoimmune and immunological disorders. A single organ, site, or a widespread effect may be seen. The factors influencing include the source of the stem cell, the age of the patient, a factor called as conditioning, and the prophylaxis given for this procedure. Historically, this was one gentleman. He was himself a microbiologist, and this is a publication in the New England Journal of Medicine. And it was followed by chemotherapy and radiotherapy, this bone marrow transmission. In experimental animals, splenocytes from non-oncogenic strains helped in hematopoietic recovery. Severe complications, as in the case of blood transfusion itself, can be fever, illness, etc. Secondary or R.A.T. disease. This is what I wanted you people to know. R.A.T. is the last product of a species which is immunosuppressed, and it has got all other features such as the growth and the nutritional deficiency. Later, there is a graft versus host disease. This one I would like you people to kindly memorize. There are different types of these transplants. One is an allogenic transplantation from the hematopoietic stem cell. It can be the bone marrow or the umbilical cord. Two is peripheral blood also has got stem cells. Third one is solid organ, such as those with rich lymphoid tissue. Kidney is rare, liver and heart quite common. Transfusion of unirradiated products and whole blood transfusions in a case of severe combined immunodeficiency syndrome. The graft versus tumor. The success depends on certain things. Broad-based immunosuppressive treatment will have to be given. However, it reduces the graft versus tumor benefit. The treatment is with minimal impact of Holy Grail. Holy Grail is supposed to be a container in which the magic medicine can cure many a disease. The history itself is, it was introduced in 2014. Now, there can be an acute one. Graft versus tumor. Success depends on graft versus tumor effects. It is broad-based, and whenever there is an immunosuppression, it can reduce the benefit of the graft versus tumor action. This is the Holy Grail, supposed to be a container which will produce the wonder medicines. And in 2014, this was published. Acute introduced graft versus tumor. The success depends on the graft versus tumor effects. It is a broad-based immunosuppressive treatment. However, with more of this, there is a reduction in the graft versus tumor action. The Holy Grail is a container in which magic medicines could be transferred. And this was supposed to be age-old. The acute has got a period of about 10 to 100 days, whereas chronic is more than 100 days. An overlap of these is possible, which I will be explaining in a tabular form. These are the organs which are commonly affected, and the mimics will be in certain conditions such as viral infections, such as hepatitis and colitis and drug-induced reactions. The pathophysiology of the graft versus host disease. Here there is a recipient conditioning. It can be because of infection or the introduction of any form of an antigen, and there is a lipopolysaccharide, the macrophages, and the mediators are being used. Ultimately, you find that there are the dendritic cells which act upon the donor cells. Now, donor T cell activation is over here. Now, what happens is there is a draining lymph node and then there is a proliferation of these cells. Ultimately, there is an effector phase in which can be the gut, for example, there is a target tissue and ultimately it can be the skin or the liver or the GI. So there are the three stages: recipient conditioning, donor T cell activation, and effector phase, ultimately resulting in a graft versus host disease. Three criteria are there. Billingham. An immunocompetent graft is always administered. The recipient is immunologically different from the donor, and the recipient is immunocompromised and cannot destroy the donor cells. This is important. That is why you find that the donor is active, whereas the recipient is immunocompromised or drained. Acute reaction, an overview. It follows allogenic hematopoietic stem cell transplant, and this will be the reaction of the donor cells against the host tissue. A great deal of morbidity and mortality we have mentioned, and this is reduced by means of radiotherapy and chemotherapy, leading to inflammation. The activated donor cells will be interacting with the host cells, and this is the incidence over here. There are many factors which are influencing, and there can be certain associated findings such as fever, rashes, hepatitis, and abdominal bleeding and diarrhea we have already seen. This is a criteria for it, called as a Glucksberg-Seattle criteria. So these are the various grades for it, and ultimately it is being given a particular grading of the reaction. And this incidentally is the, I hope you people are able to see it. It is the Fred Hutchinson Cancer Center, Seattle. Seattle is a place. The current classification of the graft versus host disease are this. Acute is less than 100 days. Chronic is more than 100 days. In chronic, there is no time limit. Sometimes there is an overlap syndrome which has got features of both acute and chronic. And there is a reference, an open book. Again, the same source. The organs affected. These can be the various changes which I shall be telling you. The skin, the liver, and the gastrointestinal tract. The histological features will be, again, I shall be telling you these things. So you people should specify the histological reactions as well as the stages. In grade, there is a basal vacuolation, and then there is an individual cell necrosis, followed by confluent one, then sloughing of the epidermis. In the liver, on the contrary, there can be a bile duct damage, bile duct stasis can be there. Biliary epithelial cells have got hyperchromatic nuclei and vacuolation, and there is a periportal inflammation. This again is given in it. So the classical ones are the skin, liver, and intestine, which I have already mentioned, whereas the non-classical ones can be the other organs and tissues. Kindly go through it. In the skin, as I told you earlier, there can be a perivascular lymphocytic infiltrate, the epidermal infiltration with the inflammatory cells, basal cell vacuolation as I am seeing in some areas, apoptotic changes, chronic lichenoid dermatitis, exactly it is somewhat like that, and sometimes it can be sclerodermoid, morphia, and lichen sclerosis like. So this is a case of a cutaneous reaction. And yet another one, wherein I am able to see a band of inflammatory infiltrate, some amount of sclerosis setting in. And there is a various changes as we had mentioned here. There is an increase in the rete ridges and the inflammatory infiltrate, thanks to pathology outlines. In the liver, for example, these are certain things which are important. I find that there is a vacuolation and some kind of a ground glass appearance which can mimic a hepatitis. There might be cholestasis, not very clear over here, and there is a hyperchromatic nuclei in the biliary epithelium over here. Inflammation, necrosis is there, but this grading is not robust. So these are the changes that are there, and there is a periportal inflammation as I can make out in this region. Gastrointestinal, it is widespread. So by endoscopy, I am able to find out some kind of a sloughing. In this one, there is a congestion and probably microulcers in the mucus. Here, there is individual cell necrosis and loss of the individual crypts. Grade 3 is loss of 2 or more adjacent crypts and then widespread denudation. This is somewhere in between 2 and 3. The colonic biopsy, you find that there is a stem cell transplant and there has been a widespread destruction and there has been replacement by fibrosis, and the arrows point out to the presence of the neuroendocrine cells. How do you diagnose it? This is a flow diagram for a clinical diagnosis. A chronic one, you find that the skin, the various organs can be affected. The changes I've already mentioned. The acute, this will be the 3 important organs, you'll have to mention them. Sometimes they are recurrent, there can be persistent, and there can be a new or a late onset. Sometimes there can be an overlap between these two also. So this is one. So there is a transplant that is given and you find that the stem cells, they are going inside, and you find that here there is a kind of an immunosuppression at the same time. Usually it is the host that will be rejecting the transplant, but in this case, the transplant rejects the host. What are the signs and symptoms? So one thing is important. What are all the mediators? There is a cytokine storm, just as you see in the thyroid. So this can be initiated by means of irradiation or a chemotherapy. Various mediators are being released. And ultimately, you find that there is a graft that is being injected or infused. And there is a graft versus host target organ reaction. So this is a slide of the lung wherein I am finding interstitial fibrosis and inflammation. Mimics in various biopsies can include viral infection or drug-induced reactions as in the case of skin. This is a very important one. I would like you people to kindly explain this. Here there is the recipient conditioning. There is a tissue damage that is there initially. It is a small intestine that has been made. So there is a lipopolysaccharide and you find that the various markers such as the tumor necrosis and the interleukin-1 can be released. At the same time, you find there are again another set of interleukins from the host tissue, host versus the donor cell, and then there is a reaction. So there will be the cytotoxic T lymphocytes and the NK cells coming into the action, and there is a target cell apoptosis that occurs, which is shown over here. So various one, I would like you to kindly read this text, the same picture over here, but there are basically 3 stages. 1 is an afferent phase, 2 is the efferent phase, and 3 is the effector phase. Afferent is the activation of the antigen presenting cells. Efferent is the activation, proliferation, margination of the effector cells, and the effector phase is target cell destruction. Prevention will be by means of DNA-based typing, HLA matching, use of umbilical cord blood for the case of severe graft versus host disease. the T cell depleted marrow transplant can be done. Greater risk of graft failure is there. There can be a relapse of the cancer, immunodeficiency can lead to infection, and there can be much difference between the T cell depleted and the T cell depleted transplant. An ounce of prevention is worth a pound of cure. The treatment will include glucocorticoids, extracorporeal photopheresis, mesenchymal stem cells, fecal microbial transplantation. Fecal microbial transplantation. You must have heard of this yeast treatment, etc., after a course of antibiotics for replenishing the mucosa. Others can be pentostatin, photobiomodulation, and electrostimulation. This is given over here in the text. It was hard graft all the way and a good result in the end. This is again a very beautiful diagram. There is a precondition of the transplant. There can be a radiotherapy and the chemotherapy, and there is a damage to the epithelial barrier. And ultimately you find there can be the various cells which are inducing the reaction, and they produce the various macrophages. Sometimes, as I had mentioned, there can be a thyroid storm during this adaptive immune activation. Finally, there can be a damage to the end organ because of the reactive T cell mediated mechanism, thanks to biomedicine. This particular one can be used as a summary. As I told you earlier, mention the patient factors. It can be the age, the organ function, or the size. What are the infection factors? Whether the patient is having a neutropenia, lymphopenia, etc. And what are the other infections that could be transfused? It can be fungal, viral, bacterial, etc. And immune reconstitution. Thymus is supposed to have potential in it. And the disease factors which are going to be handled. It can be cancer, it can be immunodeficiency, autoimmunity, etc. And acute graft versus host disease. You find that there can be the various treatments for it. Thanks to Frontiers for this particular reference. And this is one. In one case, I'm having an acute graft versus host disease, whereas in another, there is an acceptance. Here, the stem cells are there. There is a specificity for these viruses. There is a reconstitution of the immune mechanism, and there is normal immune reconstitution, no graft versus host disease. Whereas at the other end of the spectrum, there is an immune deregulation or a dysregulation, allogenic reactivity for graft versus host. If you want to stop me, you better start digging my grave, because I won't stop until I die. A nice quote. Okay, see you again.